Hello, Biology Class 1406 and Professor Day. My name is Cindy Garza, or I like to go by my middle name, Marisela, and today I'm going to be discussing my genetic disorder, Duchenne Muscular Dystrophy, or DMD for short. I'm going to talk about what this is, and then I'm going to talk about the phenotypic features that you can see in this disorder. So what this is a genetic disorder that causes the gradual degeneration of skeletal muscle, which leads to other complications. So this can affect any muscle in your body, even the muscle in your heart, the muscle in your lung, your diaphragm, any muscle. DMD is the second most common single gene disorder in Western countries. Some of the clinical features that you'll see in it is a delay in walking. So usually children will start walking around 16 months, but children with DMD, they won't start walking until about 18 months. You'll also notice a clumsy gait, sometimes walking on tiptoes. The age of onset is pretty young, though sometimes it's hard to notice at a young age. If you can see in this little chart that I have in the bottom right, these were 144 boys that were studied, and these are the ages in which they were diagnosed. Some other complications that may happen with DMD is osteoporosis or any other orthopedic issues. Orthopedic having to do with the bones, so scoliosis is very common in children with DMD. Lumbar lordosis is also common when sitting, and what that is that's the little curvature in the spine that you see here. Sometimes it happens when you're sitting, and sometimes you even get it when you're standing. Other symptoms is they can't run, they can't jump, they can't climb stairs. They usually have somewhat of an intellectual disability that can be as extreme as retardation, or it could be as minor as just needing a little extra help in tutoring in school. ADHD is also common sometimes. Kappa enlargement is common. Cardiomyopathy and impaired heart is very common because the muscle in your heart, it's not beating as fast as it should, it's not beating right, so that'll lead to heart complications. Respiratory complications is also common, and vital capacity. Alright, so now I'm going to talk about the etiology and pathogenesis of DMD. So DMD is the most common form of muscular dystrophy in children. It occurs 1 out of 3,500 male births. The DMD gene codes for dystrophin, the protein dystrophin, which is a key element in the structural part of muscle fiber. So basically, if you don't have dystrophin, or if there's a deficiency of dystrophin, that's what causes your muscles to be sensitive and more prone to degeneration. DMD is caused by many different types of mutations, but the most common ones are intragenic deletions. And what this is basically the gene is inactivated, almost like a null mutation. So when the gene is inactivated, the protein is no longer being produced, and that's what leads to the absence of dystrophin or the deficiency. So these are the most cases, and its most common deletions are between exons 45 and 47. There's so many other types of mutations that can happen: point mutations, missense, frameshift, splice site mutations. But the intragenic deletions are definitely the most common ones. Alright, the inheritance. So DMD is an X-linked recessive trait, which means that only males are affected by this. The reason for this is because as males only have one X chromosome, when they get that affected X chromosome, they are affected. Whereas females have 2 copies of X chromosomes. So even if they have an affected X chromosome, they have the backup X chromosome, the other chromosome, to still be able to produce the dystrophin. So female carriers of DMD also have a 2/3 chance of having an affected son with no family history and being a carrier of the changed DMG. 1/3 of the other cases are de novo mutations. Treatment and diagnosis. So there is unfortunately no cure for DMD. Any kind of treatment that a DMD patient will get is basically revolved around symptoms and improving their quality of life. It is a terminal and progressive disease, so it doesn't get better. So far there's no cure. There's no way to fix the deficiency in dystrophin. Usually doctors will give a prognosis of about 20 years. Some of them can live longer and some of them can live shorter than that. Again, it all depends on the cases. What really takes their life is any kind of pulmonary or cardiac complications that they have. So the better they are in keeping up with that and taking care of the heart and the lungs, the longer they can possibly live. Corticosteroids, however, is actually said to be one of the best drugs in treating DMD. Again, it doesn't cure it, but it's said to not only improve symptoms, but it also improves their walking, their ability to stand up, etc. Everything that has to do with their muscles. Diagnosis. So there's 3 ways to diagnose a DMD. They can do a clinical diagnosis, and basically after they see a progressive symmetrical muscle weakness, that's how they make the diagnosis. They can also do a muscle biopsy, which is when they take a piece of the muscle and they are able to check the levels of dystrophin. So if they see the levels are very low or not even there, that's how they can tell they have DMD. They can also do a blood sample where they can look at the DMD gene and see if there's anything wrong with it, but this may not be conclusive, and sometimes it won't tell them for sure if the patient has DMD or not. Alright, so my case study was about a boy named Christopher Callahan who was 8 years old. He had DMD. He could walk, but he couldn't run, jump, and he had to have his parents pick him up to climb upstairs. He wasn't given an official prognosis, or it wasn't stated in the video, but he was expected to live up to about 20 years. Again, that's the average time for any patient with DMD. Christopher uses a modified scooter that his father made after not being able to find a pediatric wheelchair. So he uses his scooter. I don't have a picture of it here, but he would use it to go around in his school and basically go any kind of long distance. Even though he could walk, it was still better for him to not walk long distances. He also played sled hockey. He had a slight verbal impairment, which is kind of common. He would visit Cincinnati Children's Hospital biannually just to make sure his heart, his lungs, and everything was going okay. There weren't any major complications. He would have to take steroids that weren't FDA approved, and his mother had to have them shipped in from Spain, which was very costly. Christopher also took supplements for heart, cramps, and muscle breakdown, and he would get physical therapy at school, as well as a little extra tutoring from his teacher. Alright, so now I'm going to go over the evolutionary tree of my DMD gene. And much like Professor Day's evolutionary tree, you can see that we are very similar to primates, which I found interesting. Not only that, I also found interesting that all of these animals had at least a 90% similarity percentage. So that tells me that DMD is not only common in humans, but is also very common in animals. So as you can see, I have a chimp, your typical chimpanzee, a bonobo chimp, here we are, humans. We have gorilla, orangutan, and a macaque. I thought that was a cute picture. And we all branched off about in the same time, and we're all, as you can see, still very closely related. And over here, my 2 outliers, I have the star-nosed mole and the bottlenose dolphin, which branched off way earlier than we did. So I found that very interesting, and that concludes my presentation on Duchenne Muscular Dystrophy. It's a pretty tragic disorder to have, but hopefully a cure will come out for it soon.